from her and the Queen Margaret University, including Sophie being one of the authors here. The political economy of health financing reforms in Nepal. Basically, I start with the context, as Sophie and Professor Sanam clearly highlighted how important it is to really understand the context first and how the context influence any reform. In case of Nepal, I mean, we had a prolonged political conflict, civil war, more than a decade civil war, um, that ultimately led to a peace agreement, and then the constitutional, where the health was enshrined as a constitutional right. The context is very low financing expenditure from government on health side, which created a high dependency on external development funding with a high out-of-pocket spending. Federalization actually reinforced, particularly on the wider social inclusion, and that led to a kind of pressure to bring the reform in place. Also, strong political skills, technical skills within the team, which were able to maneuver the leverage the political mileage, along with the international alliances, was the case in Nepal. The reform windows basically aligning, as Sophie clearly mentioned, three kingdom is problem, policy, and political streams. However, compared to what we observed in Thailand, Nepal, we did not have a very strong, organized change team. Rather, our team seemed to be more fragmented, but mixed of several actors working on the same issue over time, but not as organized as in Thailand. Basically, we picked up two areas to have a deep dive case study on it, and one is Safe Motherhood Program, which is also known widely in Nepal as AMA, Safe Delivery Incentive Scheme. This scheme was basically the reform was strongly linked with the evidence linking to the MDG5. The focus was largely on creating a high demand for facility childbirth in Nepal. We did a deep dive analysis of the DHS and other relevant data to really identify the equity status in terms of institutional delivery and home delivery, and that clearly one of the agenda came out was a strong, wide and inequity in terms of service and health outcomes. So the funding on this was one of the biggest concern of the government when the reform agenda triggered was how do we sustain this financing, if we cover nationwide. So it started, there was quite a good negotiation between the development partners and the government, including the Ministry of Finance, Ministry of Health, and the External Development Partners Group on how this financing could be sustained. So there was kind of consensus developed among these various parties that initial funding with the donors and then gradually transitioning to domestic funding. And as of today, this AMA program is fully funded. This demand side scheme is fully funded by the government domestic funding with a very, very small amount from the external development partners. So we started with a small pilot in one district under the Safe Delivery Incentive Scheme, and then gradually with the evidence providing to the political consensus that it was later on scaled off nationwide. The provider on this was largely this Safe Motherhood program focused on public health facilities under the government, but gradually incorporated the private sector because there was a clear demonstration from data evidence suggesting that a good number of women were using private facilities and paying high cost for childbirth. So gradually started with the private sector as well. The financing mechanism, largely it was output-based reimbursement, where the input-based budgeting. Um, this scheme reform largely allowed the respective facilities who were implementing ARMA program with the flexible fund, so they could use for other purpose. And conditional cash transfer to beneficiaries, largely one of the strong evidence that demonstrated that many women do face financial barriers to seek institutional delivery. So that was the big push in terms of providing a conditional transfer to the beneficiaries. The flexible status of this program was one of the key priority program of the Ministry of Health and Population. The another reform that we closely looked at is the free care. It came as a political driver, just launched post-Civil War as a political dividend to the people. When Maoists joined government, there was a wider discussion on how the political process could deliver a peace dividend to people. So free care actually came in that backdrop. The initial focus was basically on the free listed essential medicines, which were already free, many of them, but they continue to add other essential drugs in the list. There was no direct funding from development partners, but there was a sector-wide approach, pool funding mechanism been put in place to really support this reform process. The gradual expansion of the free care that was basically observed with continued addition of new categories of free drug to deliver the basic healthcare services and delivered through public facilities, primarily input-based financing. And ultimately, this free care scheme gradually evolved as a basic healthcare service package, which was developed in 2020, linked to the constitutional right to provide free basic healthcare services to the people. Of course, the federal context, where the local levels deliver and federal provides funding through the conditional grant in health sector. Like Ansumali mentioned, a lot of strategies in Thailand, and this also links to the Sophie's presentation. Under these various categories, as I said, we did not have a very organized change team in Nepal, but under the stakeholders category, looking at the political leadership, there was strong coordinate and coalition building. Basically, as I mentioned earlier, is the delivering peace dividend in change context that actually supported the reform. And there's strong use of synthesized evidence to justify the reform agenda within the political front. The bureaucratic politics is largely the partners supported generating high caliber evidence through their existing embedded technical assistance to the Ministry of Health. And that helped really to trigger this discussions. This is not something one-off thing. So it continued, took several platforms to discuss this in multiple iterations. And the leadership advocacy aligned with the global agenda. It was very important to mention here that MDG closely linked to the safe motherhood program in Nepal and wider political reduction goal was tied up with the reform agenda, in order to gain the national consensus to the level. Also, the organizational strength in case of Nepal, that sector-wide approach that basically brought donor and the government together to discuss about the policy priorities and reform priorities, and this was taken one of the priority areas for reform. The budget politics, again, pool funding mechanism, which basically provided a flexibility to the government to really take this reform forward towards the implementation level with the contribution from donor. Again, the external actors, as we also heard earlier, very strong external actors, but there was quite a good evidence to be, synthesized to provide to convincing argument for this reform and leveraging with the international network, international initiative like ISP and P4H initiative that was closely linked, and that also contributed to garner support across the partners. Again, on the beneficiaries politics, it's basically encouraging more participation and transparency and accountability. There was a strong community engagement. It is the case in Nepal, particularly mobilizing 50,000 plus female community health volunteers and quite a sizable number of mothers group did contribute to the positive outcome at the implementation level. The interest group politics, yes, there's evidence use again, identified supply side barriers. As I mentioned earlier, we had a rigorous review on it, mobilizing support from the civil society organizations and basically building coalition with the parliamentarians and other groups. So this is my final slide with the key reflections. Not very different from Thailand, but the context was completely different between Thailand and Nepal. The timing matters. We had a long, prolonged political conflict in Nepal with more than a decade-long civil war. And later on, with the comprehensive peace accord signed between the government and the Maoist, that really led political momentum. And also using these health indicators, deeply analyzed health indicators, and demonstrating inequities of the decade, then partnering with a strong coordination was really instrumental to take the reform forward. Again, crisis as a catalyst, conflict and short, not necessarily the favorable one, but that basically helped driving the equity agenda forward in Nepal. We did observe the parallel and fragmented tracks of reforms of few initiatives going on, which actually led to suboptimal operational efficiency when there's unconnected reform agendas were put in place. Right-based approach, which is very strong with the engagement of civil society, that helped reinforce the reform agenda. Twin track financing, the supply side and demand side financing, that was really key, instrumental in terms of taking this initiative forward towards sustainable gains. The partner role, particularly the development partners, as well as the civil society organization, helped synthesizing evidence, financing, and enhancing the governance mechanism. But again, multiple partners coordination was a challenge. To sum up with my couple of priority actions here is system strengthening is absolutely important to lead this reform, the higher gains in the long run, particularly at the implementation level. Enhancing regulatory mechanism, any reform along with the strong, robust mechanism of monitoring, that particularly helps the expanding coverage, particularly important when you have conditional cash transfer to the beneficiaries. And integrating this reform track, as I said, aligning health financing reform with the local agenda, with the social protection policies is really important. And Nepal is gearing towards that by identifying various social protection initiatives and how this reform could link to the protection policies in the long run. Finally, don't stop. Sustaining the policy dialogue is absolutely key. Maintaining stakeholder consensus to really have a higher gain of this reform process. Thank you very much. Back to you, Chandra.
Thank you, Sushil. Wonderful presentation.